Hello everyone, welcome to another video by Phoenix Medical Lectures. In today's video, we'll be seeing Arrhythmias part 2. So the last video, we ended it with focal atrial tachycardia. So we'll continue with atrial flutter. So in atrial flutter, we see something known as the sawtooth waves, which is like two waves together. Okay, it's known as the sawtooth waves, and we see it in lead 2 and 3 and also in AVF, these places, and along with that V1. So apart from this, there's something known as the 2:1 ratio of these waves in the QRS complex, which we can appreciate here. There are two waves and then there's a QRS complex and again two. So there's a 2:1 ratio. So this we see in atrial flutter. Coming to AVRT and AVNRT, so which is the atrioventricular reentrant tachycardia and atrioventricular node reentrant tachycardia. So there's absent P waves, there's no P waves. Here we do not appreciate any P waves. So if there's an absent P wave, and also sometimes there's a retrograde P wave, which is the inverted one, in leads 2, 3 and AVF, then we term it as AVRT or AVNRT. So for focal atrial tachycardia, atrial flutter and AVRT or AVNRT, how do we treat it? We try first with vagal maneuver. If that doesn't work, we give adenosine, followed by beta blockers, calcium channel blockers, and then finally cardioversion. And then for long-term treatment, we give radiofrequency ablation of the affected tissue. Okay, that was about narrow QRS with regular rhythm. Now second, we're going to see narrow QRS with irregular rhythm. So what are these? Atrial fibrillation, atrial flutter, but with variable block, and then multifocal atrial tachycardia. These are the conditions we're going to see. So first we'll see about atrial fibrillation. So there's something known as the fibrillation waves here. So which is basically like very closely placed irregular kind of waves, which we term as fibrillation waves. So there's also the rhythm, as we can see here. This is closely placed and the next QRS there's a distance. This is irregular. So irregularly irregular rhythm. So this is about atrial fibrillation. Coming to atrial flutter. We already saw atrial flutter in narrow QRS with regular rhythm. So in that we saw something known as the sawtooth waves. So that's going to repeat. There is sawtooth waves here also, but there's something, an alternate 2:1, 1:1 ratio. There we saw a 2:1 ratio of the sawtooth waves and the QRS complex, but here there's alternate. So sometimes there might be 2:1, sometimes there might be 1:1 ratio of the waves. So there's also something that we appreciate here, which is the irregular rhythm. So there's irregular rhythm, sawtooth waves, and 2:1, 1:1 ratio of the waves in QRS complex. Then we term it as atrial flutter with variable block. Coming to multifocal atrial tachycardia. So in multifocal atrial tachycardia, we have morphologically different P waves. So here we see there's a different kind of P wave. Here again it's different. Here also it is different. So if there's three morphologically different P waves, then we term it multifocal atrial tachycardia. So what might be the cause? It might be COPD, it might be pulmonary embolism or CHF. Coming to treatment. For all the three conditions that we saw before, atrial fibrillation, atrial flutter with variable block, and finally multifocal atrial tachycardia, for all these conditions, there's a similar treatment. We give adenosine, followed by beta blockers, calcium channel blockers, and then cardioversion. Again, for long term, we try radiofrequency ablation, but especially for atrial fibrillation, there's something known as the CHAD-VAS score. So if that's more than 2, we resort to anticoagulants. Okay, coming to wide QRS with regular rhythm. What are the conditions we're going to see? Ventricular tachycardia, SVT with bundle branch block, antidromic AVRT. So normally the ventricular tachycardia and SVT, supraventricular tachycardia with bundle branch block, there's a lot of similarities between these two. So we need to find a way to differentiate it. So what are the differences? That's what we're going to see. So the QRS is more than 0.14 seconds in ventricular tachycardia, whereas it is less than 0.14 seconds in SVT. So there's AV dissociation extreme right axis deviation in ventricular tachycardia, which is not present in SVT. Finally, the patient might be a known case of cardiovascular disease in ventricular tachycardia, and that might not be the case in SVT. Okay. So what is this treatment? So the reason we need to differentiate between ventricular tachycardia and SVT is that the treatment completely differs. So for ventricular tachycardia, we give amiodarone, procainamide, and then we try cardioversion. For SVT, we give adenosine. And the reason we need to properly diagnose an SVT or a ventricular tachycardia is because if we give adenosine, that might actually worsen ventricular tachycardia if the patient is actually having ventricular tachycardia. So adenosine, there should be cautious use of adenosine. So what about long-term treatment? Again, radiofrequency ablation. And if there's a ventricular tachycardia, we need to look for signs of myocardial infarction because it might be due to that. And also, finally, we'd give a automatic implantable cardiac defibrillator. So final one, wide QRS with irregular rhythm. So in that we have polymorphic ventricular tachycardia with normal QT interval, polymorphic ventricular tachycardia with prolonged QT interval, atrial fibrillation with Wolff-Parkinson-White syndrome, and atrial fibrillation with bundle branch block. Okay, so in that, so we can appreciate polymorphic waves here. Okay, apart from that, there's wide QRS. If there's wide QRS and polymorphic waves, all of these. The only difference is this fibrillation with bundle branch block, and this might be the most common cause with wide QRS. So that is atrial fibrillation with bundle branch block. So coming to PMVT with prolonged QT interval, which we already know, it is torsadis d pointis. So there might be more than or equal to 500 milliseconds of QT interval. So if it is torsadis d pointis, what do we give? We give magnesium sulfate, we try to replete potassium, and then we discontinue medications which we think might cause the condition, and overdrive pacing or isoproterenol. And finally, okay, PMVT with normal QT interval. Then we give amiodarone, procainamide, cardioversion, like the normal one that we saw for ventricular tachycardia. And then finally, defibrillation. If it is atrial fibrillation with Wolff-Parkinson-White syndrome, this is dangerous because this might develop into ventricular fibrillation, which is a condition. It's a no pulse condition. It doesn't present. So that we might need to treat with defibrillation and CPR. So normally there's an increased rate, it's fibrillation. So for this, we do not give any AV node blockers. That might actually precipitate the condition. So adenosine, beta blocker, calcium channel blocker, digoxin, we do not give this because it might lead to ventricular fibrillation. So how do we treat it? We treat it similar to PMVT with normal QT interval like amiodarone, procainamide, all of that. Next, coming to atrial fibrillation with bundle branch block. So we see the QRS morphology, whether it's same throughout. And then the treatment is beta blockers, calcium channel blockers, and cardioversion. So what is the long-term treatment? We give radiofrequency ablation and automatic implantable cardiac defibrillator. So this was about tachyarrhythmias. Coming to bradyarrhythmias, we already saw that classification. It was sinus bradycardia, first degree heart block, second degree heart block, which was divided into Mobitz 1 and 2, and third degree heart block. So coming to sinus bradycardia, there's just decrease in the heart rate. That's all. There's no other visible change. So there's sinus bradycardia. After that, we have first degree heart block, where the PR interval, it is going to be prolonged. It's going to be more than 200 milliseconds, okay, and a normal P wave. So that is first degree heart block. Coming to second degree heart block, in that we divided into two. So there will be a long PR interval and a missing QRS, okay, a long PR interval and a missing QRS. We call this second degree heart block Mobitz 1. And if there's a normal PR interval and a missing QRS complex, then we term it again second degree heart block, but Mobitz too. Okay, that's the difference. Next, normal PR interval, missing QRS. The only difference is wide QRS. Okay, apart from normal PR interval and missing QRS, there is a wide QRS. We term it third degree heart block. Okay, so for second and third degree heart blocks, what is the mechanism? So normally cardiac output is heart rate into stroke volume. So we know this is bradyarrhythmias. So there's a decrease in heart rate. So if there's a decrease in heart rate, there's going to be a decrease in cardiac output. So blood pressure is cardiac output into total peripheral resistance. So if there's going to be a decrease in the cardiac output, there is going to be a decrease in the blood pressure. So that will lead to hypotension, altered mental status, and chest pain. So how do we treat it? We give atropine. We already saw that the parasympathetic nervous system will normally decrease the heart rate, and the sympathetic nervous system is going to increase the heart rate. So if you're giving atropine, we're going to block this. So if the parasympathetic nervous system is going to decrease, then the heart rate is going to increase. If we are going to increase the sympathetic nervous system by giving epinephrine, then again the heart rate is going to increase. Apart from that, we can give something known as pacing. So that might be transcutaneous, transvenous, or permanent pacemaker. Okay. Then we need to treat the cause. So we try to cover all the causes. So first is inferior wall MI, which might be due to a right coronary artery block. So we first check whether it is a STEMI or NSTEMI, which is like ST segment elevation myocardial infarction or non-ST segment elevation myocardial infarction. Then we check for cardiac troponins if TROP-T is positive. And then percutaneous coronary intervention. Okay, we place a stent. And then hyperkalemia, if it is present, we try to treat it with calcium, then insulin, D50, albuterol, and then we try to correct if there's acidosis, and finally Lasix. Okay, if there is the cause is because there's a beta blocker, calcium channel blocker, or digoxin. These are the causes. Then for beta blocker, we give glucagon to suppress. Then for calcium channel blockers, we give calcium. If that is the cause, we try to give an antidote, calcium. Then digoxin, we give digibind. Okay. Coming to Lyme's disease, we give ceftriaxone. And if there's hypothermia, we try to keep the patient warm. And if there's hypothyroidism, we give levothyroxine. Thank you.